Okay, let's unpack this. You're prepping for the MSRA, right? Staring down that list of high-yield topics.
Yeah.
Today, we're doing a deep dive into one that's really crucial to recognize. Eczema herpeticum.
Definitely.
We've got the core revision stuff here, and our mission is simple. Cut through the noise, get you the absolute key insights you need.
Sound good. It's definitely a topic where rapid recognition is everything.
Yeah.
Think of it this way. You're on a shift, maybe PEDS, maybe Derm, and a child comes in. History of pretty bad eczema.
Okay.
And suddenly, like, over just a couple of days, they've got this really painful, rapidly spreading rash.
Right, that's the classic setup. It's not just, a bit more redness or itching from their usual eczema. This is something new and fast.
Exactly.
So what is eczema herpeticum fundamentally?
So at its core, it's a severe viral skin infection. The key thing is it happens specifically on skin that already has an issue, like eczema.
Yeah.
Most often, that's atopic dermatitis.
Yeah.
And the virus causing it, usually herpes simplex virus.
The cold sore virus.
Typically HSV1, yeah. The same one.
So it's not just having the virus or just having eczema. It's that perfect storm. The virus hitting that already vulnerable skin.
Precise.
How does that actually happen? Like the pathophysiology.
Well, what's fascinating here, and really important for understanding why it's so serious, is that the virus basically exploits the existing defect in the skin barrier.
Because the eczema.
Right. The skin's normal defenses are down. It's like leaving the door unlocked.
Okay.
This lets the virus get in easily, it starts replicating really fast within the skin cells, and then spreads widely. That causes major inflammation and those characteristic painful lesions we see.
And it's not just skin deep, right?
No, it can definitely lead to systemic illness. It's not just a superficial thing.
That barrier defect really is the Achilles heel. Thinking about that patient scenario, who else is particularly at risk apart from just having eczema?
Well, besides any type of eczema, especially atopic dermatitis, the other key risk factors include having a weakened immune system.
For any reason.
Yeah, any reason. Also, being young kids and young adults are most commonly affected.
Why them particularly?
Probably a mix of factors, maybe less developed immunity, perhaps more skin-to-skin contact in kids. Also, frequent scratching.
Which damages the barrier even more?
Exactly. And of course, direct contact exposure to someone who has active herpes lesions.
You mentioned kids and young adults. So epidemiology-wise, we don't know exact numbers, but it hits those with atopic dermatitis hardest.
Yeah, and it's known for that really rapid onset and being very painful.
That rapidly progressing painful rash, that's the big alarm bell, isn't it?
Absolutely. Clinically, what you'll see are these clusters of fluid-filled blisters, vesicles appearing quickly.
Right.
They often break open, leaving crusts and erosions behind. And fever is also really common.
And location, often widespread.
Often widespread, yeah. The face and neck are very common sites.
Okay, and this is where that mental image or the picture in your revision notes becomes vital. There's that one sign, the visual hallmark.
Yes. This is probably the single highest yield detail for spotting it. You need to look for the characteristic monomorphic punched-out erosions.
Punched-out erosions. Describe those again.
Think of them like small, really uniform, circular, kind of shallow ulcers. They look almost like someone used a tiny hole puncher on the skin.
Wow. Okay.
Usually about 1 to 3 millimeters across. If you see those, plus that rapid onset rash in someone with known eczema.
Eczema herpeticum jumps right to the top of your list.
Exactly. So like if you see a kid with bad eczema suddenly get these tiny, almost perfectly round sores popping up everywhere fast, think herpeticum.
Got it. See those lesions? Think eczema herpeticum.
Yeah.
But what else are you quickly ruling out in your head, the differentials?
Good question. You got to consider other things causing angry skin in someone with eczema. Could it be bacterial, like impetigo?
Right.
Another virus? Even fungal?
Yeah.
Or maybe a severe allergic contact reaction on top of their eczema?
Or just a really, really bad flare of the eczema itself.
Or just that, yeah. But the speed, the pain, and especially those specific lesions usually help point you away from just a flare.
So you suspect it clinically based on the history and seeing those punched-out lesions. Do you always need tests to confirm?
Well, the diagnosis is primarily clinical. You see the signs, you know the history, you should act fast.
Don't wait for labs.
Ideally, no. Initiate treatment if your suspicion is high. But confirmatory tests do exist. You can do viral cultures, PCR testing from a swab of a lesion.
Like a viral swab.
Exactly. Or even a Zank smear, looking for those viral changes in the cells under a microscope.
Right.
But again, the clinical picture, those erosions, that's key.
Speed is vital. So management, thinking UK guidelines. What's the first line?
Antivirals. That's the absolute cornerstone. Acyclovir is a go-to drug to get the virus under control.
Okay.
Supportive care, too, of course, for the pain, fever, skin care, and close monitoring.
And there's a specific point about kids, right?
Yes, very important, high-yield point in children, because it can get severe quickly and spread systemically. Hospitalization for intravenous IV acyclovir is often needed. That's standard guidance.
So, prompt antivirals, often IV and admission for kids. If you catch it early and treat it properly, what's the outlook? The prognosis?
Generally, the prognosis is good, provided it's recognized quickly and you start those antivirals appropriately.
Early treatment is key.
It really is. It's crucial for preventing the worst outcomes.
And speaking of worst outcomes, what are the potential complications you need to watch out for?
Okay, so you need to monitor for secondary bacterial infections. That broken skin is an easy target.
Makes sense.
Scarring can happen. A really serious one is ocular involvement, the virus spreading to the eye.
That's an emergency.
Absolutely. Needs urgent ophthalmology input. And then, particularly in people with weakened immune systems, there's a risk of the virus disseminating, spreading to internal organs, which can be life-threatening.
Wow. Okay. That really highlights how serious this can be, all starting from a rash on compromised skin. So the key takeaway for revision: eczema herpeticum, severe viral infection on eczemated skin, needs urgent antivirals. Recognize it by rapid onset, pain, vesicles, and critically, those monomorphic punched-out erosions.
Don't delay treatment if you suspect it.
Exactly.
And, this raises an interesting point to think about, considering how the virus exploits that broken skin barrier. How fundamentally important is really optimizing the day-to-day management of the patient's underlying eczema. Could that actually reduce their risk of getting this severe complication in the first place?
That's a great point. Basic skin health is the first line of defense. Makes total sense. Right. That's probably all we have time for on this deep dive. For more free MSRA revision resources, do visit freemsra.com, and for the full premium revision toolkit, head over to passthemsra.com.